trusty highlighter out. All right, so let's work on this lumbar spine a little bit. So we talked about these in lab yesterday, so we went over the lumbar parts of the bones again, which you guys are pretty good with, I think. We went over the ligaments, but now let's dig into these ligaments a little bit deeper. And the first one I didn't talk about in lab, but what about an intervertebral ligament? What in the heck is that? So inter means between, vertebrae means vertebrae, in between the vertebrae ligament. Well, that's the intervertebral disc is actually considered an intervertebral ligament, if you will. In fact, it's kind of an old term, but just in case that ever popped up on boards. And the parts of the nucleus, again, and we'll get crazy into this as we go through the program here. But it's made up of a nucleus pulposus, which is about 80% water. Then we have these sheets of lamellae, which are type 1 collagen. They have a special arrangement. Yes. Again. Oh my gosh. Jeez, I swear. I'm going to start doing this live on YouTube. Well, sorry guys, I guess we'll have to throw this up on YouTube again. I could try to restart it. But yeah, I don't know what to say. They're working on it. So well, you can follow along again with the PowerPoints. I'm on PowerPoint number 3. And let's just keep going. So this will be on YouTube then. That's weird because I just had the other classes and I didn't have any trouble with it. Anyway, so here's the nucleus pulposus, annulus fibrosus, made up of lamellae. And then really importantly, still on slide 3, you can see the sinovertebral nerves. These are really important because this is where pain comes from. And we'll talk about this when the time comes. But you can get rips and tears in the back of the disc. And then this blue stuff, this nucleus pulposus, can herniate out. And it can get out in here and cause horrible pain so bad that sometimes you have to have the disc cut out and to do fusion. And a very small percentage of people, but that's like Tiger Woods. That was the surgery that he had. And yeah, I won't get too much more into that because we're going to cover that in detail. But let's go over the ligaments. Now sometimes these collectively are called the posterior elements, or the posterior ligaments. And we have ligamentum flavum, interspinous ligament, and the supraspinous ligament. Remember we looked at those last time, or we looked at those in lab. And then we have the facet joint capsules, which I don't think I showed you, but those are just capsules around the facet joints. And let's dig into these. So anterior longitudinal ligament. Remember yesterday it was really easy to see. It's super wide, and it's on the front of the vertebral bodies, and it covers most of the vertebral bodies, discs and end plates. It's made of type 1 collagen. And there's a real cadaver picture, and this isn't perfect either, but it looks like it's been kind of dissected away here because you can see it more over here. But this is, I mean, it doesn't look like the pictures. It's kind of hard to visualize this stuff on these cadavers. Many of these are really old people, and they don't look quite as fresh and strong. But it extends inferiorly into the sacrum, and it goes all the way up to the occiput. And it covers every single vertebrae except for S2, S3, S4, S5, and the coccyx. Here's a like important, make a note of this in your slides. We're on slide number 7. It grows steadily wider as you descend. So in the cervical region, it's just a little thin cord, And in the lumbar region, it's much, much wider. So that's an important characteristic. The posterior longitudinal ligament does exactly the opposite of that. It is attached, some of the fibers are attached to the vertebral end plate. Does it attach to the disc? It doesn't really attach into the discs in the cervical lumbar spine, and even in the thoracic spine, maybe about 50% of it attaches into the intervertebral disc. So Bogduk says that it should not be considered part of the annulus fibrosus. All right, in the cervical spine, we said it's more like a narrow cord. It's not very thick at all. We'll look at that more when we get to the cervical spine, especially between the top axis is C2, that's the second bone down, and occiput. I'll show you a picture in a minute. And it helps attach occiput to the body of axis and a tubercle of atlas, and that'll make more sense when we get to the cervical spine. And there's another ligament, even though it's small and skinny in the cervical spine, there's a ligament that is lateral to it that kind of makes up the difference, and that's called the anterior atlanto-occipital membrane. Right, so here is a picture of the anterior. This is a A to P view, so we'd be looking right at the, we're slide 10 now. We're looking right at the patient's eyes. There's the mouth. And so we have a skinny ligament, the anterior longitudinal ligament right here. And out to the side of it right here is the atlanto, or the anterior atlanto-occipital membrane, it's called. Not super important, but the posterior atlanto-occipital membrane is really important. And we'll talk about that when the time comes. You can see, let's go back there quick. See the facet joint right here? I'm still on slide 10, looking over at the atlantoaxial joint. This one is kind of naked, but this one has a joint capsule, and that's what a joint capsule looks like. It's just a capsule, so the cerebrospinal fluid doesn't leak all over the place. So here's the picture we had in lab, right? So, I mean, we already went over this, but here's the anterior longitudinal ligament here from the A to P view. And yeah, there it is. All right, if you want to get kind of more down in the weeds on this ligament, so it's really made up of a set of a bunch of individual fibers. So microscopically, there's just not a set of fibers spanning these. They're spanning every 2, these fibers. These fibers are spanning every 3. These fibers go all the way 4 before they attach. So histologically, they would be attaching into the bones here on each side. And that makes it a very strong type ligament. And now this is more important, so I always ask this question: what does the darn thing do? So it resists traction forces. Like if you grab somebody's head from above, you're like hanging from the ceiling, and you grab somebody's head and you pull up, that's traction. That, biomechanically speaking, that has a special word. It's called superior coronal translation. And we will be doing the biomechanics lecture, so you'll know exactly what that is, but I wanted to tell you what the correct word was. Clinically, it's just called axial distraction, so it resists axial distraction. It mainly kicks on with extension, so if you bend your head back, it becomes tight, which makes sense. So you could say it resists extension of the cervical or lumbar spine, or any spine, all the regions of the spine. And can be damage in a whiplash accident, where you are hit from behind, the head goes forward and back. So you'll treat hundreds, if not thousands of patients. I'm slide 14 now. Hundreds of thousands of patients who've suffered whiplash, where they're rear-ended and the body goes forward but their head goes back. Hopefully they'll have a headrest. You could see if they didn't have a headrest, their head would really hyperextend, and it would pull these ligaments, slide 14 still, pull these ligaments tight and maybe even rip some of them. So here's a patient who was in a car accident, rear-ended. They came in, wanted treatment, And never treat a car accident, a fresh car accident patient. If they haven't been x-rayed at the hospital, you're insane if you're going to treat them without an x-ray, especially if they have pain. This patient didn't even have that much pain. And sure enough, we took an x-ray, and there's a chunk of the anterior longitudinal ligament you can see right there broken off the bone. That's called an avulsion fracture. And there are some embryological conditions where a growth plate doesn't fuse and it can look just like this. So that's called a persistent epiphysis. Persistent epiphysis can look exactly like that. So sometimes it's hard to tell between the two. You'll learn that more when you go through the radiology program. So the anterior longitudinal ligament and the posterior longitudinal ligament a little bit, but mainly the anterior longitudinal ligament has a disease that can affect it, and it's called DISH. Slide 16 now. Diffuse idiopathic skeletal hyperostosis. And as you can see in this parasagittal cut, if you look and see, because here's the bones, here's the vertebral bodies right here. This is front. This is back. You can see in the front, there's definitely a flow of bone here. And we looked at that vertebrae in lab yesterday that had all the bone spurs. So these are like crazy bone spurs, and the bone spurs are so bad they actually fuse the front of the vertebrae together. So when you see more than 2 or 3 segments fused like this, that makes you think they have a condition called DISH. And you'll learn all about that as you go through the program, but you'll run into that occasionally. If this happens up in the cervical spine, it can cause something called dysphagia. It can interfere with your swallowing, and it can cause dysphonia to interfere with your voice. And so here, if we look, here's your, let's say there's your eyes would be, or there's your eyes right there. There's your lips here, there's your mouth. Here's the posterior, here's the anterior. So we've got kind of a mid-sagittal view. You can see all this, these little spikes right here, and all this. This patient has DISH, and they have these 2 gigantic, it looks like a bird's beak. So those are bird beak osteophytes. But this is a patient with DISH, and you can see here, here's the nasopharynx coming down, here's the oropharynx. You'll learn these terms next quarter. And there's the laryngopharynx. You can see how it's pinching right there. Right, the uvula, that little thing that hangs down from your throat. I'm on slide 17. It would be hanging there. And you can see how when you swallowed a big, like, chewed up steak, a big bolus, that's called, the food, you can see how that would be narrowed. And it's you have trouble swallowing when that sort of thing happens. So that's called dysphagia. If it flat out hurts, then it's called odynophagia. Dysphagia is just trouble. I mean, it doesn't flat out hurt, but it's annoying. Odynophagia is flat out pain. So, yep, that's a patient with DISH, and they got those bird beak spurs. On slide 18, you can see the giant, I blew it up. You can see C2, and you can see, it really, there's his eye right there. I mean, it looks like a bird, doesn't it? There's his beak. And the food would go right here. The food would push, it would fill all this up. Have to go down the esophagus, and you'd have trouble because of that beak. Posterior longitudinal ligament. The other thing I wanted to say, I forgot a slide on the ALL, because somebody asked me last quarter and I forgot to put the slide in. Who is the innervation? What nerves supply the anterior longitudinal ligament? They're considered non-carrying pain fibers. They're actually members of the sympathetic system that plug into the front of the disc. And based on the research, they don't seem to carry any signal of pain. So we think if you have an anterior disc herniation, it's completely meaningless. So that's the story there. Now, the posterior longitudinal ligament, slide 19. And so, yep, so this is seen throughout the spine, runs through the lumbar, thoracic, and cervical spine. Now here's the board question, a really easy board question you can't miss. This one narrows as you go from cervical to lumbar, so it's just the opposite of the anterior longitudinal ligament. The anterior longitudinal ligament is cord-like, really thin and ropey looking in the cervical spine, but the lumbar, or the posterior longitudinal ligament, is very narrow in the lumbar spine compared to the cervical spine. So that's a definite, since I've been in school, that's a board question that you just have to know that one. So anytime there's a weirdness like that where two things contrast, that's a good type of board question. All right, so it also covers the posterior vertebral bodies and discs. 21 now we're on. Extra fibers course laterally from the midline and cover the posterolateral parts of the disc. These lateral fibers are said to give kind of a serrated appearance. I tried to show you them yesterday. Here's a different view we didn't look at, and you can see them right here. The main part of the ligament would run right through here, but then we have these pieces that go out, and they really don't go out much farther than that. I think that one author was a little crazy. I'm still in slide 22, but yeah, that's what that looks like. Slide 23 now, just showing you that again there are different bands of fibers here. So we have some bands that go 2 segments, some go 3, some go 4, some even go 5. So this ligament is very strong when you have an arrangement like that. Different lengths of fibers within the ligament. And unlike, here's another great board question, slide 23 still. Unlike the anterior longitudinal ligament, which doesn't attach to the disc, these do blend in with the posterior annulus fibrosus of the disc. So in fact, the center portion of the disc, which would be right here, still on slide 23, the center portion would be very strong because of these extra ligaments. That's why disc herniations usually occur paracentrally, kind of off of midline. PLL morphing on slide 24. So unlike the anterior longitudinal ligament, so here's another difference between the two. So you should be writing these differences down on note cards or however you study. Make sure you know these differences. The posterior longitudinal ligament doesn't technically go all the way to the occiput, which is the top bone. It does, but it changes names because the fibers get really thin. So they gave it a new name, as the picture here in 24 shows. Above C2, it changes names to the tectoral membrane. The tectoral membrane. So the PLL, posterior longitudinal ligament, actually ends at the body of C2. What about the other direction? It goes all the way down into the sacral canal. Usually at S1 or S2, then it morphs into a ligament you already know, called the deep dorsal sacroiliac ligament. And that's about the story with 24, 25. So here's another clinically important thing, the weak spot because disc herniations happen posteriorly. That's where the nerves are for them to crush. So there is a weak spot, and that is in the posterolateral region. I'll show you a picture here in a second, but let's actually take a look. Let's go to 26 and take a look. Page 26, you can see the posterior longitudinal ligament, but see the little W there on slide A, or in picture A, there's a little W. That's a weak spot where the annulus fibrosus is exposed. And discs can herniate toward the midline, but when they hit the anterior longitudinal ligament, it's so strong they kind of squirt just lateral to the main part of the posterior longitudinal ligament, and they pop out right here where that W is. And that by far is the most common place a disc herniates, and that's called a it's called a paracentral disc herniation. So right and left paracentral disc herniations are by far the most common. They also respond the best surgically to a discectomy as well. Okay, moving on. 27. So here's one of my patients. came in with severe right radicular pain. So here's my pet peeve. What's the difference between radicular pain and radiculopathy? And it drives me crazy when people don't use this term. Even some instructors still don't use these terms right. Radicular pain is an adjective. It describes a sensation of pain radiating down a leg or radiating down the arm in kind of a band-like pattern. And it doesn't have to be pain. It can be burning or tingling or cold numbness or lightning. Everybody feels this radicular pain difference. Radiculopathy, that is a diagnosis. That you only use the term radiculopathy after you've done a neurological exam and you have found something messed up. You found, for example, the reflex is decreased, or the patient's sense of their ability to feel, like your fingers or a little needle poking along your skin. There's a numbness there. If you have those two findings, or the muscle is weak, like they can't do a single leg calf raise, they can only do 2 on the left, they can do 20 on the right. That's a weak muscle. If they have leg pain, and this positive neurological finding, then you can diagnose them with radiculopathy. But radiculopathy doesn't mean they have radiating pain. That's just a diagnostic finding. So you will use that one for the rest of your chiropractic lives. So don't mess that one up. So this patient anyway, they had radicular pain. Neurological testing, they had an absent Achilles reflex. I don't think you know this yet, but Achilles usually is controlled mainly by the S1 nerve root. And then they had numbness in the lateral foot compared to the right foot. Or the left foot was normal, the right foot had numbness in the lateral foot. So that's also the S1 dermatome. So it's looking like S1. Had him do single-legged calf raises, super weak on the right. Again, the calf is mainly S1, a little bit of L5. So I'm pretty sure he probably had a disc herniation at L5 compressing the S1 nerve root. And here is a MRI picture, still on slide 27, and you can see the disc, the back of the disc, and there's a gigantic herniation just smashing the S1 nerve root to pieces. And these sides are reversed. This is the left over here. So the nerve root is right there. It's happy. That's the left side, but where's the right one? The right one is crushed. So you're going to have so many of these cases. You can treat these people with flexion distraction, and us professors differ greatly with regard to grade 5 manipulation. I am vehemently opposed to adjusting someone with a ripped disc, because adjusting is for mainly the facet joints, but you'll get different opinions and you can form your own opinion when you go through. Anyway, slide 8 is the same deal. There's a Tarloff cyst. You don't have to worry about that. Okay, so back to the boring stuff. PLL function, what does it do? Well, it also resists that coronal distraction or axial distraction, like pulling, like if you're up on the ceiling somehow and you grab somebody's head and you pull up. That's a distraction force. So it also resists that distraction, or officially anterior sagittal, that would be coronal translation. Superior coronal translation is what it would be resisted. Did I not put that in there? I don't see it. It also resists the PLL when you flex forward. That's called anterior sagittal rotation. Oh, there it is, anterior coronal translation. That should be superior on slide 29. It should be superior. I have to make a note of that. Superior coronal translation. So you could say it resists lumbar flexion. Yeah, just picture you bending forward. It's going to get tight. It's going to pull that tight. Just the opposite of the AALL with that regard. Okay, is the PLL innervated? Yes, it is innervated. I want you to memorize this nerve forever. Here's another thing that you'll take with you forever and ever and ever. because the patient may have a herniated disc, or they may have a tear in the disc and they have horrible pain, and they say, "Doc, where's my pain coming from?" Don't just say oh, you got a pinched nerve, you got a slipped disc. That makes you look so bad. I mean, you guys are supposed to be spinal experts. Tell them what the problem is. The problem is they have an irritation of one of the nerves that supplies the discs or is attached to the disc. And that nerve is called the sinovertebral nerve. Slide 30, sinovertebral nerve. AKA recurrent meningeal nerve is a strong AKA for that, and we'll talk about why that is later on. But it's definitely a pain generator, the posterior longitudinal ligament, unlike the anterior longitudinal ligament. There's another great board type question, because there's a difference between the two. The ALL is supplied, or the PLL is supplied by the sinovertebral nerve, and therefore it can be a pain generator if it gets inflamed. On slide 31, we have an overhead view of the thecal sac, which you guys should be pretty good with right here. Number 15 is a traversing nerve root. But you can also see little lollipops, number 4, connected to the front of the thecal sac. So those are nociceptive fibers. Those are of the sinovertebral nerve. The main root of the sinovertebral nerve is here at number 20. And yep, so that's the, and you can also see in the little yellow lollipops inside the outer portion of the disc. So the disc is very well innervated by these little lollipops as well. And that's enough for that. We'll get into this wiring more later. Right, so again, in next week's lab is going to deal with this, so I won't get into it too much. On slide, I guess the numbers covered, that would be 32. But you can see the sinovertebral nerve. You can see number 3 is the sympathetics, that's the gray ramus communicans. Look it up at number 19 toward the top of the disc. You can see little lollipops. There's not very many of them, but there are some lollipops, but those are sympathetic fibers. And those control blood vessels. We have blood vessels in the disc. I didn't draw them there. And that's what their responsibility is, to control the blood vessels, the size of those blood vessels. There's no pain fibers mixed in there as far as we know. Right, there's the answers on 33, and that is the end. Let me make sure I save this, and I'll start getting this up on YouTube. And again, I apologize. This has never happened like this bad before. So I don't know what's going on. Discard.